Thanks for this presentation about robotic surgery in endometriosis. And we are sorry for exceeding time limit. The next presentation will be about outcome of international ovarian tumor analysis results by Dr. Wouter Froyman, Professor of Gynecology, University of Leuven, Belgium. Welcome.
Really, we are honored to have Professor Dr. Wouter Froyman with us today. Welcome, Doc.
Thank you so much. Good morning, everybody. Thank you, dear chairs, for the kind introduction. Thanks to all to welcoming me in your nice country. I'm very honored to be here physically in person as a representative from the International Ovarian Tumor Analysis Steering Committee group. So we will move from surgery towards diagnostics. I have here a small overview of my talk. So for whom it's coming. Yes, a small introduction on Annexal Masses and the IOTA project itself. We will go through a standardized description, some diagnostic methods, some words on diagnostic, some conservative management, and then some guidelines for clinical management. And everything that I will show is based on results of the IOTA studies. So what do we want? We want to be able to distinguish between these different types of lesions and findings on the ovary or the tube. So patients with a normal ovary, luckily most of the patients, and also patients with functional lesions, so cysts that are expected to resolve spontaneously, hemorrhagic cysts, bleeding cysts. So here you will rarely need to do any intervention because it will disappear spontaneously. Patients that have benign neoplastic tumors, which you can see on the right, those patients might still be eligible for conservative follow-up. So they don't always need surgery, as we will see. But if the patients have pain, of course, they will benefit from being operated on, but then you can perhaps prefer minimally invasive surgery. And then on the bottom, patients that have borderline tumors, invasive tumors, or metastatic tumors, they will have benefit from being referred to specialist oncological gynecologists or gynecological oncologists. But there's also a difference. Patients with borderline tumors are young and they will often still want children, so you can choose for a fertility sparing treatment. Patients with invasive tumors, they will need more aggressive surgery, so debulking surgery and also systemic therapies. And then patients with metastatic tumors, for instance, the breast or the colon or the biliary tract. So those patients, the treatment will be depending on the origin of the primary tumor. So breast cancer that has spread to the ovary has another approach than a stomach cancer, for instance. So that is what we want to do before we start to do any intervention. We want to be able to distinguish between these different possibilities. And the IOTA study was founded in 1999 as an international multidisciplinary group of researchers and clinicians. So there are oncologists, radiologists, gynecologists involved. And throughout several decades already, there has been inclusion of about 40,000 patients based on standardized definitions, which we will see later on. So on all these phases, and here I show you IOTA phase 1 until 5, but in the meantime, we have IOTA phase 6 and 7 going on. And also Professor Mona Abulgar, who is sitting here, is one of the key researchers representing Cairo University in the study. So we see that on IOTA phase 1 until 4, all patients had surgery. So we had histology as a gold standard, as the outcome. But then IOTA phase 5, and I will show you some results, was a really novel phase, which was not only collecting patients for surgery, but also patients in conservative management. So based on the results of IOTA phase 5, we will be able to show you the risk that the patient with a cyst that looks benign will in the end have a malignancy, or will you see the risk that the patient will have a torsion of the cyst or a rupture. So that is really novel findings from this study, IOTA phase 5. But before we start to do any study or to do any ultrasounds and to use simple rules or IOTA UpNext model to improve your diagnostics, it is very important that everybody that is involved in this is using the same language, the same terminology, the same descriptions, the same measurement techniques to report the findings. So if you make a medical report and you do follow-up of a cyst in a patient, you want to know if the measurements are the same over time, or if there will be a change. But if you measure things always in another way, what is then the value of your reporting? Besides that, if you want to use IOTA methods like the simple rules or the next model, it's very important that you use the descriptions as they are intended to be used. So a papillary projection, for instance, is a protrusion of 3 millimeters. If for you that's 6 or 7 millimeters, that's a different definition. And then you cannot really trust the results if you apply any of the IOTA methods. And also in the IOTA project, because it's an international multi-center study, it's important that everybody involved in patients inclusion uses the same terminology and measurement techniques. So I'm not going to go over the terminology because that's a lecture on its own. And yesterday this was done by Professor Abulgar. But this is the paper published in the year 2000 in the White Journal. And here you have a list of all the several definitions and measurement techniques that you need to use when you assess an ovary or a lesion inside the ovary. And these slides and these definitions are also available on this high definition posters, which are freely available on the IOTA website. So you can download them and print them to put them in your ultrasound office. When you scan your patient, it may be some assistance. So let's assume that you all now know the terminology. Then you can move to some diagnostic methods. And to improve your diagnostic skills, of course, there are some tools to help us. We know that a pattern recognition or a subjective assessment by an expert ultrasound operator has the best performance. Somebody that did ultrasound for decades in his or her life, has seen many ovarian cysts, has seen many cancers, and is sometimes able to recognize some typical malignancies or can distinguish between benign and malignant. But it's not always possible for all of us. So people that are just finished their training, that are young gynecologists, they want to have some assistance. And there's the risk of malignancy index, but that's already 30 years old. And it's a little bit now overdated or outdated. And there are now the more recent IOTA methods, which are more powerful, also having a higher performance to distinguish between benign and malignant. And I will just show you two of them. I will talk about the simple descriptors and the most recent UpNext model, which is the most promising model to have the diagnosis of cancer and also some subtypes of malignant tumors. So what are the descriptors? Some types of cysts are able to be recognized by the most of you, all of you. We know that an endometriotic cyst has a certain appearance. We also know that a mature teratoma has a certain appearance. So for those tumors, it's not necessary to apply simple rules or a next model because it's so simple to recognize those lesions. And we know from the IOTA study that if you can apply one of these simple benign descriptors, that in the end, the outcome of the patient will be more than 90% sure benign. So this is some way to sort out the easy cases. And which are those features or descriptors? We have those four. So the presence of a unilocular tumor with a ground glass echogenicity in a premenopausal patient less than 10 centimeters in diameter. We know that that is very suggestive for the presence of an endometrioma, as you see there. I see that the clips are not going. That's a pity. No clips. Second, a unilocular tumor with a mixed echogenicity and shadowing in a premenopausal patient, also less than 10 centimeters in diameter. That's a safety margin. That is very suggestive for the presence of a teratoma, a mature dermoid cyst. And then on the left bottom, an unilocular anechogenic tumor with regular walls and also a diameter smaller than 10 centimeter is suggestive of a cystadenoma, as you know, a serocystadenoma. And then on the right bottom, we have other types of unilocular tumors with regular walls and with other types of content. Like here you see some echogenic dots. That's very suggestive for a mucinous cystadenoma. So with those four descriptors, you're able to sort out almost 40% of all of the cases. So in general, if you have 100 cases of ovarian tumors, 40 of them you will be able to classify as benign when you apply these descriptors. But what if you're stuck and you're not able to recognize one of these features? Then we would recommend the use of the UpNext model developed by Professor Ben van Kaaster, the statistician of the IOTA group. That is the first mathematical model that is able to calculate a risk. It can calculate the risk of malignancy, but besides that, it's also able to predict the risk that the patient has a borderline tumor in percentage. the risk that it's a stage 1 primary invasive ovarian cancer, the risk that it's a stage 2 to 4 primary invasive ovarian cancer, or the risk that it is metastasis from another origin like the breast or the stomach that has spread towards the ovary. So we call it a multi-class prediction model. It will not say only benign malignant, but it has several classes in the malignant group, which is of course very useful for your clinical practice. If you know that the patient has a very high risk of having a tumor that comes from the breast or from another organ, you will not immediately start to do an aggressive surgery as it would be a primary ovarian cancer. So the approach will be different. And how do you use UpNext? There are 3 clinical variables. We have the age of the patient, the type of center, an oncology center or not, the serum C125, which is optional, in contrary to the RMI, where it's a mandatory value. C125 is optional, so you don't need to have it to calculate the risk of malignancy, and it will also not help you to improve the calculation of the risk of malignancy. But if you have a malignant tumor, it will help you to have it in the model to distinguish between the subtypes of malignant tumors. It will be helpful to know whether it's a metastasis or primary ovarian or a borderline. So to calculate the risk of malignancy, you don't need it, but to assess the subtype of malignancy, there C125 will help. And then we have 6 ultrasound variables, which are very easy. It's the maximal diameter of the lesion, the maximal diameter of the largest solid component, whether or not there are more than 10 cyst locules, the number of papillations, acoustic shadowing, and ascites. So these variables are very easy to be collected and not time-consuming at all. But how do you use it? Because there are 9 variables and it's a logistic regression model. I would like to challenge you, but there's nobody here that can calculate the percentage risk of malignancy because it's a very complicated formula. And I could not even put it on one slide because it's too extensive. So to help us, luckily we have some calculators. There is a calculator available online on the IOTA website, which is depicted there. There are some applications, so you can put it on your smartphone. So on your smartphone, you have the software and you can enter the variables and you can instantly calculate it on your phone, or luckily, and even more easy, so when you scan your patients on some more recent ultrasound machines, like see in the picture, there is often the software already embedded in the machine. So when you scan your patient, and I will show you the next slide, you can collect the variables without loss of any time, and you have the results at the end of your scan, and you can, if you want, you can discuss the results with your patient. But I don't think that the clip will run, so this is a movie, but I don't know if somebody can activate it or not, because it doesn't work from here. So this is an example of how the software is in the machine. Yesterday it worked, but if it doesn't work, it doesn't matter. So for some reason it doesn't work. Maybe there, yeah. Thank you so much. So on the left side of the screen, you see that you have the fields of the IOTA variables. So the age, the oncology center, those are default variables. So you can have them immediately linked to the patient's file. And then you have to start to measure. And first you go and look for the largest diameter of the lesion, which is there. And automatically it's filled in 29 millimeters. And then you go for the solid tissue, and you can see that there are some papillations inside of the lesion. And there you go for the largest diameter through the largest solid components. So that will be a horizontal diameter, as you see there. So that's about 14 millimeters. And then the questions, are there more than 10 locules? No, there's only 1 locule. Number of papillations, there are 2. Shadows, yes, no ascites, and up. You have the risk of malignancy, which is here 10%. So without a loss of a lot of time, you're able to calculate the malignancy risk. I will proceed with the next slide now. So I would like to convince you that it's very easy to have an accurate risk estimation. Usually in clinical practice, the IOTA group would recommend the use of a cutoff of 10% to indicate malignancy. So if the risk is above 10%, we would classify it as malignant. Here you can see some studies that have validated the UpNext model. Thank you. In independent research groups. So we have here about 10 different studies, and you can see that the summary AUC is 0.94. Above 0.9 is regarded as an excellent approach to distinguish between benign and malignant. So these are independent studies also by people that are less experienced in ultrasound. So they are not all ultrasound experts. Also people that have a very basic training in the IOTA methodology are able to get a very good result to diagnose malignancy. So it's now seen as the best possible approach to diagnose ovarian cancer. Then we can also show you some results on the IOTA phase 5 data. So it's a study from last year in the British Medical Journal. And as you know, we have collected patients that had surgery. So we had histology, but there were also patients in follow-up. So this IOTA phase 5 study is like the global population of patients with adnexal lesions. So not only the very suspicious ones, but also patients that have benign looking tumors. And on this database of about almost 5,000 patients, we looked at the AUC of the different models. And you could see that the adnex model with or without C125, as I said, there is not a big difference in distinguishing benign from malignant. It has a very good AUC of above 0.94. That is better compared to the risk of malignancy, which you can see on the top. Oh, something happens. My apologies again for the technical issues. Try to do it. Yeah. Solved. Okay, so on the IOTA phase 5 data, up next is the best strategy. A few words on the conservative management. So we know what we have to use in patients to diagnose cancer, and we know what to use the next model to diagnose the subtype of tumor. But what happens to tumors that seem to be benign? So patients that have cysts that look certainly or probably benign, what has happened if you follow them up over time? Is there really a risk of torsion, of rupture, or malignancy? IOTA phase 5 will tell you the answer. So this paper was published 2 years ago in Lancet Oncology by the IOTA group. And here we see what happens to patients in conservative management after 2 years of follow-up. So you see that we started with about 2,000 patients there with certainly reassuring or probably reassuring features. And then over time, you can see that about 15% will undergo surgery over 2 years, in the first 2 years. But if you look at what happens to the patients that had surgery, you see overall that the blue curve is the largest curve. And then you can see that there is written there are no mass complications. That means patients underwent surgery because they requested for it. They said, I don't want to have longer this follow-up. I want to have it taken out. Or there might be a treating physician or a treating gynecologist that said, well, I know you're in follow-up, but I would feel safer that you have surgery. But you see, most of the patients that had surgery, there's nothing. There's no malignancy, no torsion, no rupture, no complication. There was no complication at all seen on the lesion. And the really bad scenarios you can see are the invasive tumors, the torsions, the borderline, the ruptures. They are very flat. It's the very flat curve. You can hardly see it. Then that's a very reassuring result. So after 2 years of follow-up. So if you look at those 2,000 patients, there were only 7 invasive tumors, 5 borderlines, only 7 ruptures, 4 ruptures and 7 torsions. So people often counsel patients, well, you have a cyst, it has to be removed because it will give a torsion. But you can see that on 2,000 patients, there are only a couple of torsions, in fact, diagnosed, and a very small group of malignancies. But then it's also very important to look at what type of malignancies and why there were malignancies. So these are patients that had a malignant outcome. There were 7, and 5 of them had primary invasive ovarian cancers, and there were 2 secondary metastatic lesions. But if you look at it, it was a very small time period between their recruitment in the study and then their surgery. You can see that there was 1 patient that had surgery after 1 month, after 2 months, 3 months, and only 1 patient was after 6 months, so in 11 months' time had surgery. So there was a very small delay in diagnosis. So the patients were not walking around a long time with the cancer. It's very short after the recruitment. And that's very interesting findings. More of that, it's also reassuring, but you cannot see it on that slide. So if you look, there were merely stage 1 tumors and then type 1 tumors. So the more favorable types of tumors. So there were not that many high-grade serous ovarian cancers in high stage. So there were very favorable subtypes of tumors and merely diagnosed in the first months after the diagnosis in the study. But also interesting to see, those are the pictures of the recruitment scans. So those patients were selected for conservative management. To look at that now in retrospect, I think maybe these patients were not so ideal to be selected for conservative management. And if you would apply our next model on this, you would have a very high risk of malignancy, much higher than what would allow you to do conservative management. So we can conclude that these are false negative diagnoses. So the investigators in the study missed here already the diagnosis of cancer, because these are the scans after follow-up, and you don't see a lot of change. The morphology of the tumors is almost the same. So we think that these are false negative diagnoses, and this happens with all types of imaging. It's the diagnostic methods. You will sometimes miss a cancer. So these are not transitions from benign to malignant. These are false negative diagnoses. I'm coming to the end of my talk. So what happens if you do follow-up in this IOTA phase 5 study and you compare it to surgery to all of the patients? So if you look at the study, and we started with 1,919 patients, and if you would compare this to the results of possible surgical complications, what if we did not do follow-up, but what if we had removed all of these lesions without doing follow-up? Then you can look at some large trials in ovarian cancer screening, and you see a risk of surgical complications ranging from 3.5%, and I'm talking about major complications, so bowel leakage, major adhesions, bleeding, organ lesions, up to 15% in the PLCO trial. So if you would do surgery in your patients, you will have major complications. And now we do a small simulation. From the 1,919 patients in IOTA 5, there were 823 postmenopausal. What if all of these postmenopausal patients underwent surgery? Then we would have caused more. So 26 patients, ranging to 109 patients of our cohort, would have suffered from major complications if you would have done surgery in all of them instead of follow-up. So this really defends the possibility of doing conservative management in many of the patients. And this was picked up in international media, objective and subjective media. So the story was heard in the world that there was now the possibility to conservative management. And then I will end with some guidelines from clinical management. This is very new from last year and then beginning of this year. So we have now the ORATS algorithm. So, you know, BI-RADS for the breast. ORATS also exists to classify the patients in certain ORATS classes depending on the risk of malignancy. And the next model is one of the tools to have the patients classified in the correct group. And this is the hottest new, or the hottest news, or the most recent news. This is published some months ago, contemporarily in the different journals, and it's an international guideline endorsed by ISUOC, ESGO, the IOTA group, and ESGE. So where ultrasound is recommended as the first step to assess patients with adnexal tumors. And then if you don't have an expert ultrasound operator available, that the next model should be used to classify the patient in the correct risk category. And then again, if you have the patient referred to the oncologist, in the second step, you can apply ADNEX with C125 to distinguish between the certain types of malignant tumors and to have the appropriate treatment strategy. So this is very novel. It's an international guideline which is now accepted, and I hope that many people will start using it. So I will conclude. So first of all, there's the importance of having standardized terminology when you do an ultrasound assessment. Most of the, or a big portion of the tumors can be classified as benign by using the benign simple descriptors. And if not, you can apply the ADNEX model to distinguish between benign and malignant. But you don't need to do surgery on all of your patients. Patients with benign looking tumors can be followed up conservatively. So after 3 months, then after 6 months, and then yearly. Unless there would be changes in morphology or size. And then most recently, the ORAT system can be used with the use of the descriptors and ADNEX to guide your clinical management. Thank you for listening to my lecture. I would like to thank everybody involved in the IOTA study. Mona is listed on the left as a very important contributor to the study. And if there are more questions, or if you want to see more, you can scan this code and you will be directed to the IOTA website, where you will be updated on future courses. Thank you so much.
Thank you very much.
Really, many thanks, Professor. Really, many thanks, Professor, for your comprehensive lecture. Thank you.
It's a pleasure.